Yes, hello class. In this presentation, in this lab cases, we are going to discuss um, some of the cases for this week lab. So again, learning objective as usual, sort of identify the views. Obviously, you need to recognize some important radiological pathological correlation, and then based on those findings and those correlation, you should be able to come up with a particular diagnosis in a differential diagnosis. Also, remember clinical recommendations are important. Typically, do you require any lab test for different conditions? Do you require perhaps any additional imaging? And also consider referral to perhaps to specialists, rheumatologists perhaps, or any other kind of subspecialty dealing with certain conditions. So let's look at some of those cases. In other words, this case number one, so you get a 35-year-old male with back pain. So again, at this point, what I'd like you to recognize is a couple of important features in this case. So let's look at some of them. So I'm going to kind of point to this area. So you can see sort of lateral radiographic examination of the spine. So typically you should have noticed this particular finding. Well, what you're actually seeing is actually a bridging type of syndesmophyte, and it's known as a marginal syndesmophyte. Why? Because it actually, if you like, attaches or connects the margin to margin of the end plate. And in fact, this condition affects through the entire end plate, but typically we see it as sort of that ossification, or rather formation of that bridging marginal syndesmophyte. Now, most likely is occurring elsewhere, it's just not clearly visualized on X-ray. Another significant feature, you can see that sort of blurring in distinctness, some kind of evidence of potential, inflammation and, changes affecting the facet joints. Okay, so just by identifying this marginal syndesmophyte and changing the facet, the diagnosis of potentially ankylosing spondylitis is very high on the list because this marginal syndesmophyte, it's a very characteristic feature of AS. Other features can be seen as well, squaring of the vertebral body, even other features that sort of demonstrating a bit of sclerosis, what we call Romanus lesion, we can also see. But purely from this radiographic view, you can see that feature right there, that marginal syndesmophyte, and some of these changes in the facet joint. And that's when that diagnosis of IS should be higher on the list. In this case, you can see multiple changes sort of in this AP pelvis. You can see obviously all this sort of whiskering or proliferation, that sort of indistinctness, fuzziness of this, insertions of the connective tissue, muscles, etc. to some of this pelvic side. You can also see, changes in the sacroiliac joints, so they're not clearly demonstrated. In other words, perhaps some kind of ankylosis or fusion of the A-side joints is also seen. In addition to that, you also see some changes in the hip. We know that ankylosing spondylitis affects your root joints. It kind of spares primarily your distal sides, hands and feet, but it certainly potentially targets your root joints. In other words, root joints considered as hips and shoulders. And typically you see uniform joint space narrowing, bilateral. You can also see some of the proliferation of whiskering, and basically what we call enthesitis at the insertion of the capsule, perhaps around the hip. So typically there's a collar-like, if you like, proliferation of bone, and that's very characteristic of AS affecting the hips. Symphysis pubis, it's another area not clearly seen in this case, but certainly that whiskering, proliferation, plus changes in the sacroiliac joint, and this is advanced disease, by the way, and you can see some sort of increased sclerosis affecting this sort of, if you like, facet area. So you can see that that's known as trolley track sign, and that's ossification of the facets. Later on we'll see it, more than in this case. And of course, bridging of the spine itself with this marginal syndesmophyte forming that bamboo spine known for ankylosing spondylitis. So again, diagnosis of IS highly likely in this case, or intrahepatic arthritis, because they actually present radiographically very similar, sometimes indistinguishable. In this case, the importance, the learning sort of, if you like, outcome in this case is for us to appreciate sacroiliitis. So, for instance, you can see a 30-year-old male with back pain. If you obtain radiograph and you find these radiographic findings, diagnosis of any spondyloarthropathy, not just ankylosing spondylitis, but any of them should be high on the list. AS should be on my primary differential. Why? Because AS is the most common. In this case, you can see that sort of loss of normal white cortical line. In other words, that blurring or indistinct indistinctness or erosion affecting sacroiliac joint bilaterally. Another thing, you can see that reactive subchondral sclerosis. You can just see there's certainly more bone density just adjacent to that subchondral bone, and it primarily affecting your iliac side of the articulation. Okay, so bilateral sacroiliitis, highly indicative of spondyloarthropathy. In other features, you can see the joint appears as if it's wider. In other words, a pseudo widening. Initially, it may only affect that all these changes initially may affect just the inferior portion, i.e. the synovial portion of a side joint. However, it may affect the entire joint unit later on as the disease progresses. So that's basically evidence of sacroiliitis. What kind of lab test? What kind of further management or other further recommendation? Well, certainly lab test, typically CRP. You can do ESI as well if you like, but CRP certainly, and HLA-B27, because in AS patients you get over 90%, 92% or even greater might be potentially manifesting with HLA-B27 positive. Referral to rheumatologists, and they need some treatment for that. Now, diagnosis in the spine can actually help you to narrow down differential whether you're dealing with AS or psoriatic or reactive arthritis. So in this case, we look at elsewhere later on when we study different types of syndesmophyte. But in this case, purely from the learning perspective, again, marginal syndesmophyte and sacroiliitis, highly diagnostically suggestive of ankylosing spondylitis. In this case, another example of ankylosing spondylitis demonstrated primarily by sacroiliitis bilaterally, not many changes elsewhere. Joint cartilage, maybe a little bit decreased, but it's very equivocal. So typically both hips are relatively intact. It's hard to tell. We don't see, there's not sufficient visualization of the lumbar spine, but typically sacroiliitis is clearly demonstrated. Why? Because of that sort of blurring, indistinctness, and loss of nice white cortical line of the sacroiliac joint. And on both sides, bilateral sacroiliitis highly indicative of spondyloarthropathy, particularly AS. In this case, you can see another case of ankylosing spondylitis. How do we know that it's ankylosing spondylitis? Well, because apart from sacroiliac joints, we also see some significant changes in the spine that I'm going to point out. So as you can see, sacroiliitis, based on the information I've just sort of alluded to, in other words, some indistinctness, erosion, some sort of blurring, and that's very characteristic of sacroiliitis, involvement from the sacroiliac joint. Okay, another feature, you can see hips are affected bilaterally, sort of uniform joint space loss, concentric joint space loss. You can also see proliferation, around the capsule of the hip. You can certainly suggestive of enthesitis. But another important feature, look at this. That's formation of the marginal syndesmophyte. You can see how it's bridging just end plate to end plate, and that's very characteristic of, particularly ankylosing spondylitis, not psoriatic, not reactive, but AS, ankylosing spondylitis, or perhaps enteropathic arthritis. So we'll look at some of those cases. In this case, you can see AS is very advanced. Why? Well, because you can see those marginal syndesmophytes are very well ossified, they're very well established. You can also see squaring of the vertebral body. You can see that sort of calcification and sometimes that ballooning of the disc. Okay, and you can see also fusion, complete ankylosis without skip areas affecting the spine. This patient likely have to have changes elsewhere in the lumbar and thoracic spine, because we know AS starts in the sacroiliac joint and can work its way up without skip areas affecting your entire spinal column and basically fuse the entire spinal column. So this is your bamboo spine with very advanced AS. So in this case, we also have some complications potentially developing. So this spine is very susceptible to fracture, and when the fracture occurs, we typically deal with a carrot stick or chalk stick fracture. It's the same thing, which is very significantly unstable fracture. The other important features, all this post-inflammatory fusion and remodeling of that bone will potentially lead to canal narrowing, canal stenosis, and some potential neurological complications. All patients with inflammatory arthritis, including AS and all the others, should be tested for kind of instability and changes at the Atlanta axial joint at C1, C2, relatively early in disease. So radiographic of the cervical spine with flex and extended views. And of course, we know that any kind of manipulation to that spine is highly contraindicated. In this case, another significant features of AS. You can see those marginal syndesmophyte formation. You can see some intervertebral disc calcification, squaring of the vertebral body, and you can see fusion of the facets. So all this without skip areas, highly indicative. Of course, you're going to see some additions of sacroiliac joints. On normal imaging, you'll certainly have that. But typically, just to demonstrate from the learning purposes, this evidence of marginal syndesmophyte bridging that, end plate to end plate without any skip areas, that's highly indicative of ankylosing spondylitis. So please read this information again in detail. Learn about Romanes lesion and shiny corner, because we're going to talk about it in a second, especially when we talk about MR imaging. Now, Romanes lesion and shiny corner, these are not X-ray findings. They are actually, sorry, I beg your pardon, they are not MRI findings. They're actually X-ray CT. So there was radiographic findings that we typically see, and that indicates some sort of vertebral osteitis and changes in the spine. On MRI, we're going to see it in a minute, they're presented as corner sign. So here's the case for you. Sagittal MRI, T2 weighted imaging, so you can see some overall kind of impression. You can look at the spine and see if there's anything abnormal. Well, there are a few abnormalities in marrow. So typically you can see that marrow is some way distributed okay, but then suddenly you have that sort of increased signal intensity somewhere at this level. So you can see that marrow signal intensity, and that's certainly abnormal. In this case, you can also see there's some bridging of bone, so that's formation of that marginal syndesmophyte. As you can see, it sort of produces signal intensity very similar to bone, and that's what it is. It's literally just ossification of that annulus fibrosis based to ankylosing spondylitis and enthesitis. Similar changes are found right there at the C2 and C3 area. So, and even here somewhere at the at the fourth cervical vertebra, sort of C3, C4. So you look for those things in MR imaging, because when X-ray is unrewarding or less informative, for instance, for diagnosis of spondyloarthropathy, that's when MR imaging can be quite helpful for you to narrow down that diagnosis, and that would be kind of significant features for ankylosing spondylitis. Fortunately, spinal medulla seems to be unaffected by this process at this point. So please, review it. So that's where the arrow point to basically what I've just presented to you in the previous slide. In this case, you can see T2 weighted imaging. In this case, at this vertebral level, you can see lack, in other words, reduction in normal marrow signal, in other words. So basically because normal fatty marrow is being replaced by fluid, some kind of inflammatory process. However, in these cases, we can see there's increased marrow signals. In fact, with AS, because of changes in that marrow, initially that sort of reactive inflammatory change, but then gradually it may even be replaced by some, abnormal kind of fatty degeneration of that, and that may potentially present at perhaps increased signal intensity than your normal bone marrow on T1 pulse sequence. And of course you can see bony bridge, in other words that marginal syndesmophyte at this location as well. So it's the same case, just different pulse sequence report shown. So in this case you can see there's some evidence of corner erosion right there with some reactive corner sclerosis right there. Now we don't see that marginal syndesmophyte. Maybe if anything we can see that squaring of the vertebral body, which can be quite indicative of this process. To typically normal concavity is sort of being lost, just squaring. But that would be highly suspicious for that Romanes lesion and shiny corner, and which is sort of like discovertebral osteitis in this case. So again, sacroiliitis most likely to be present in this patient. And in fact, if it's not, then MR imaging most likely to demonstrate it. So in this case, MRI may be helpful for you to further delineate the diagnosis and perhaps confirm the diagnosis of ankylosing spondylitis in addition to history and some of the lab tests. So in this case, you can see lumbar MRI, sagittal slices. You can also see T1 pulse sequence and T2 pulse sequence. You can see some of those changes in the marrow right there at the discovertebral junction. In other words, that corner sign, which is very characteristic of ankylosing spondylitis. In this case, you can also see some of those changes in this patient. So that's highly suspicious for some of those reactive end plate changes of spondyloarthropathy, particularly AS. Maybe enteropathic, but AS more so than others. In this case, you can see another very well established disease, most likely even demonstrated on x-rays, but it's just to appreciate it, MR finding of that corner sign. You can see that high signal intensity on fluid sensitive study, stir T2 fat suppressed, and then kind of lowish signal intensity, certainly decreased signal intensity right there at the corner of the end plate on T2. Plus those arrows indicate probably that arrowheads showing into that sort of vertebral osteitis, and so there's bridging syndesmophyte formation or marginal syndesmophyte. So again, MR imaging can greatly help with the diagnosis of this condition. And again, some of this, if radiographic changes in SI joints are not clearly demonstrated and the clinical suspicion is great, so again, MR of the sacroiliac joint may be very, very helpful. And in this case, you can see that reactive edema in the sacroiliac joint. Of course, here you also see that irregularity or erosive changes in a normal bone of the sacroiliac joint. Bilateral sacroiliitis. Again, spondyloarthropathy high on the list, particularly ankylosing spondylitis. Let's look at a different case in here. So what I'd like you to appreciate in this case are a few significant findings, and you can probably see the joints where we particularly joints that are particularly affected. So for example, if you conduct your survey, radiographic survey, you can see that multiple joints relatively spared. So if you look at the wrist, if we conduct our target site, of course we're going to do ABC, in other words, alignment, bone, cartilage, soft tissues. But another important, if you like, step for us is to be able to kind of identify the target site approach. Well, we established that MCP, it's sort of, not very remarkable for anything really. Joint spacing is relatively maintained. We don't see any evidence of major erosion. Soft tissues are probably okay too. Now, the other important area, let's look at the MCP, metacarpophalangeal joints, also appear relatively intact in this case. Okay, so cortical margin, cortical line is nice and wide. There's no evidence of, erosion at the bare area, no evidence of, cartilage destruction or anything else. This area is a little bit suspicious in there because I do see maybe a little bit of inflammatory changes due to some kind of bone erosion. But on occasions, in fact, even OA can affect that area. But, what I'd like you to note is this areas in there. So typically, we can see that the target site in this case is usually distal interphalangeal joint, and they kind of multiple, but they sort of like relatively asymmetric, because on this side maybe fewer joints affected, but we do see some changes in soft tissues, okay, and also we can see some of those changes affecting the joint. And typically what you can see erosion and cartilage destruction, but at the same time you can see bone proliferation right there. And that's basically that characteristic sort of mouse ears deformity. In other words, periostitis, or periosteal, subperiosteal new bone formation followed after the erosion. So in other words, you can have that inflammatory, if you like, proliferation, hyperplasia of the synovial tissue, and at the same time, enthesitis, which will lead to, if you like, bone whiskering, proliferation, subperiosteal bone. In fact, if anything, there's subperiosteal new bone formation, increased sclerosis in that bone, certainly marked, can be well demonstrated. And that's basically more characteristic of psoriatic arthritis rather than perhaps rheumatoid. It's based on the target site approach, but also based on the appearance of the pathological changes. So that's what we call pathologic, sort of radiologic pathologic correlation. We interpret, pathological changes, that how it sort of demonstrates on imaging. So that's basically a learning case of psoriatic arthritis that differs from rheumatoid on its presentation. And of course, in more detail, we're going to discuss it in the lecture. Thank you very much.